class. So obviously this is an overview of a class that we have on allceus.com that is eligible for continuing education credits for 4 hours. It's based on Ethics in Psychotherapy and Counseling, 3rd edition, by Kenneth Pope and Melba Vasquez, 2007. Ethics, thank goodness, don't really change a lot over time. It's pretty consistent. I like consistency. So you can probably find this book either in your local library, you can find it on Google Books, and you can probably find it on Amazon. Really good book to have. So first we're going to talk about the 7 basic assumptions of ethical awareness. Ethical awareness is a continuous, active process. Enemies of ethical awareness are fatigue, habit, and stress. So let's talk about that for a second. You have this continuous, active process going on, and as you get tired, are you paying as much attention to it? Probably not. Habits. If we get into habits of doing this and doing that and doing the other thing, then we're less likely to be attuned to minute changes that may require our awareness. And stress. Like fatigue, when you're stressed, you feel like you're pulled in a million different directions. That ethical awareness that's trying to get your attention may just kind of miss the mark. So it's important that we take care of ourselves as clinicians. We need to get enough sleep. We need to take care of ourselves in all areas of our life, not just sleep, but also family, recreation, hobbies, those sorts of things, because all of that adds up to fatigue and burnout. Habits. This is where having colleagues with whom you meet periodically for consultation is helpful, because we can get into really mundane habits here and there, and we don't notice slight changes. That's where your colleagues can say, well, could this person maybe be trying to tell you this? And stress. Obviously, if you're so stressed out you can't be emotionally present or be 100% on for your clients, you really need to consider how effective you're going to be and whether it's worth meeting with those clients that day or trying to reschedule if appropriate. Awareness of ethical standards is vital, but can't take the place of human reasoning and application. We've talked in other courses about how laws set the main base level for what we have to follow. And ethics are something we aspire to, but they don't take the place of good ethical reasoning. Dual relationships, perfect example. Unfortunately, sometimes dual relationships are inevitable. So how you handle those is crucial. Dual relationships is only one area where sometimes it may not be black and white. There's some gray in there. So being aware of your ethical standards, having somebody to consult with whenever there is a sort of gray area, that way you can make the most ethical decision possible. Be aware of developments, so conclusions are not mindlessly accepted. So if there's a development in the research that says one thing, don't just automatically assume, well, the research said blah, 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 so I'm going to change how I do my practice. Until you've actually looked into what's going on in the research, how the research was conducted, what groups that applies to, etc. Make sure to remember that none of us is infallible. None of us. And even when you've got a consultant, that doesn't necessarily mean that the two of you aren't infallible. It greatly lessens your chances of mistakes, but there's a possibility that you can have that whole group thing going on and miss important aspects. So be open to contradiction, be open to constructive feedback. It's easier to pay attention to others' ethical behaviors or lack thereof than our own. Well, yeah, because none of us likes looking at ourselves and going, ooh, that may not have been the best choice. So yes, it's easier to pay attention to others. Our clients find that all the time. So what we need to do is figure out how we can pay attention to ourselves. And yes, we need to help keep the community all in line with ethical behavior and everything, but we need to police ourselves. We need to do our daily check-ins. Just like we talk about with our clients, If you're throwing focus and you're focusing on what everybody else is doing, you're going to miss what's going on right in front of your face. So you need to pay attention. And ethical dilemmas often have no clear correct answer. There's the best choice. I always hated those on tests at school. They would give you 4 different options, and they want you to choose the best answer. And there are 2 or 3 that are pretty good, and the 4th one is the best answer, but you can argue either way. My professors always used to hate it when we wouldn't have Scantrons and we'd have test books that you could actually write in, because I'd write my rationale about why I thought that was the best answer. Oh well, I'm a little stubborn that way. Judgment. Self-awareness of our theory and method provides a rationale for our actions. We don't just go into therapy willy-nilly and go, I'm going to wing it and see what happens today. We have a rationale for why we do what we do, and we need to remain very self-aware of exactly why we're doing what we're doing. When I ran a residential facility, that was one of my mantras with my staff, was whenever a patient asks you why, we need to have an answer, and it can't be because I said so. We need to be able to explain to them in what way this is furthering their recovery or their treatment process. So we need to have a rationale for our actions. And confirmation bias is the tendency to seek information that confirms our beliefs or actions. So we need to be aware of that. Yes, we're probably going to look to people who think similarly because, again, we like to be right. But it's also important to make sure that you have dissenters, if you will, in your group, or that you may have to explain your rationale periodically. That just helps kind of keep us all in check to make sure that we are taking that inventory and maintaining a rationale for our actions. Our theory and method must constantly be questioned to ensure it's in the best interest of the consumer. John, Jim, Joe, and Jane. You like how all my clients start with J names? Anyway, all 4 of them are in treatment. All 4 of them have roughly similar issues. Do we treat all 4 of them the same? My theory says no. My theory says each person is an individual, and they may have different learning styles, different preferences, different attitudes. They may have different psychosocial variables going on. Their diagnoses are the same, but they have other stuff that's different. So we need to make sure that we look at each consumer as an individual, and we need to evaluate how our actions or how our suggestions for action for the client play out in each person's life, because my guess is it's going to be slightly different for each patient. And then we need to adjust from there. So we need to make sure we are constantly checking in and not just putting people in a rote system of treatment. You come into residential, here's your treatment plan, it's the same for everybody. You get out of treatment, you do 90 and 90, blah, 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 blah. That's a good starting place maybe, but then you've got to adjust it for each individual person's unique characteristics, co-occurring disorders, psychosocial variables. That's ethical treatment. Looking at the individual and not just trying to put them into one particular pigeonhole. So, what are the authorities that we have? Well, we have ethical guides and we have laws. Both seem to provide answers, but they don't relieve us of ethical responsibility. We know what the laws are, and we need to conform with the laws and most nearly conform with ethics. So we need to advocate for our clients. We need to do what's in the best interest. Above all, do no harm. Ethical guides are intended to guide our actions, but not supplant ethical decision-making, which means you have these ethics. And when you read them, you'll find out that they're really pretty, what's the word I'm looking for? Vague isn't it, but they don't address specific issues. If you had an ethical guide that addressed specific issues, it would be hundreds of thousands of pages long. So these are general guidelines that we need to try to adhere to the best of our ability. Now, a lot of our professional associations have ethical hotlines and ethics committees that we can contact if we have an ethical quandary, and we can say, this is what's going on. I'm wondering what the most ethical decision is to make. Now, if you're talking about involuntary commitment, you probably don't have the luxury of contacting your professional association. If it has to do with dual relationships, you may. So make sure you know what resources are out there in your professional community, in your current organization. Make sure you have access to people who handle your risk management. It's always good to have an attorney on retainer of some sort that you can call up if you've got a question. Doesn't mean you're going to get the answer that day. You may have to wait 24, 48, 72 hours. So again, you may have to use your own ethical judgment, which means you have to have a rationale in place for this is why I do what I do in this particular situation with this particular client. So mutual exclusivity. Yeah, we're going back into algebra. It must be X or Y. That's the black and white thinking. It's either right or wrong. So if it is X, then it is not Y. How many times do we have situations with clients where that actually applies? There's a blending that goes on. It can be X and a little bit of Y. So we need to make sure that we don't get caught in that dichotomous thinking. Nominal fallacy. Giving something a name isn't an excuse. Saying, oh, well, I was burned out, so, normally I wouldn't have done that, but I was burned out. Well, that's not an excuse. Part of ethics is being aware of your own personal status and your own ability to properly treat and serve the patients who come to you. So if you're burned out, you need to know that and you need to recuse yourself. Or you need to do something about it. Preferably, you prevent burnout from happening in the beginning. That's not always possible. Sometimes life just kind of dumps on you. You need to have a backup plan. Compassion fatigue. That's another one that it sounds like a great excuse, but it's not. Yes, you may see 20 patients a week who have extreme trauma issues. And that can really get exhausting and trying. Or maybe you work with patients who have borderline personality disorder. Whatever the case, you take on a lot. It's very draining to be empathetic with clients. That doesn't excuse you from being aware of your own level of ability to provide effective services. Compassion fatigue, that means I'm way too tired from being compassionate, which means I'm too tired to give a crap, which means I'm too tired to be seeing patients right now. See kind of how I follow that? Giving it a name doesn't make it right. Giving it a name in court doesn't excuse you from liability. And for many people, that may be what they care about. Just because you were burned out isn't going to say, well, she was burned out. She shouldn't have seen or been able to be aware of what was going on with her client. What they're going to say in court is, well, why was she still practicing if she was burned out? Where were the stopgaps? Where were the checks and balances that helped her or him maintain an awareness of her or his physical and emotional availability? The naturalistic fallacy is another ethical issue, basing decisions on only factual statements and failing to consider ethical, moral, or professional standards. This is the law, this is what we do. Without looking at ethics, without looking at options. Now, yes, we have to follow the law, but are there caveats that we can work with? Failing to consider the uniqueness of the individual. So we need to be, again, aware of each individual situation. We have the black and white, we have the X and Y, but we also need to be aware of that gray area in there as to say, are there any other possibilities where we can fulfill our obligations under the law without completely breaching ethics? I'll give you an example. Making a report to the Department of Children and Families for suspected child abuse. Okay? That's never a pleasant call to make. It's never a pleasant discussion to have. So do you do it with or without the client's knowledge or consent? Now, of course, you have the discussion at the beginning of treatment that says, these are the reasons I can break confidentiality. So are you within your right? Yes. Are you obligated to report by law? Yes. However, do you have to do it secretly after the client leaves? Not necessarily. Sometimes, in the interest of the child, yes, that's the best case of action. Many times, you can have the discussion with the parent or legal guardian and say, okay, this report has to be made. You can either call it in yourself, in my office, and we'll get all the names and numbers and of the call taker so I can put it in my file, or I can call for you. And I can call while you're here, or I can call when you leave. Empower the client to make the call his or herself. Empower the client to be part of what's going on. Even if they don't want to make the call, sometimes they feel better if they're sitting in the room while you make the call, because they're not wondering, well, what did she say when she called? So that's that gray area. The law says, yes, you have to report, but it doesn't exactly say how that has to happen. So in the interest of empowering the client, maintaining fidelity, doing no harm, yada, 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 try to do it in the way that is both safe for the child in question and in the best interest of the parent or legal guardian. Denying motivation. Well, if you focus on the things that you didn't intend to do instead of acknowledging the things you did, then you're only looking at half the story. That's like glass half empty, glass half full. An example, I never intended to violate anyone's confidentiality. I did, however, intend to take chances sending unencrypted emails because it was easier. It's one thing that a lot of people are guilty of now. Well, I didn't intend to breach confidentiality. I didn't know how to send an encrypted email. I knew I wasn't supposed to send an email that it wasn't encrypted, but since I didn't know how to send an encrypted one, I just did it anyway. That's not an excuse. So we need to make sure we look at, just like we do with our clients, the reasons you did do it. Why was it more motivating or more rewarding to make the wrong choice as opposed to the other choice? Don't hide behind your excuses. All of these things that we're talking about are things that we regularly talk with our patients about not doing. So they need to look at both sides of the coin and figure out, why was it that you did that? Was there a rationale in your ethical decision making that supported the best interest of the client, or was it self-interest? Emphasizing the positive. Throwing focus from misdeeds by focusing on what didn't occur. Well, nobody died, thank goodness. Well, that's true, but you just got lucky this time. So we need to do a root cause analysis and see how to prevent it in the future. Everyone was provided timely services, although they weren't appropriate to the person it served. So saying all the right things with a but. Everyone was provided timely services, but they weren't appropriate. That's kind of like saying, yeah, surgery went off without a hitch, but we amputated the wrong leg. It wouldn't fly. It wouldn't fly. Yes, there's a time and a place for emphasizing the positive, but there's also a time and a place for taking responsibility. The unethics mantra. I love this one. It's not unethical if we've read about it, because everything on the internet is true, right? It's not unethical if we can identify others who do the same thing. If every other practitioner out there was practicing ethically, then we wouldn't have pages upon pages upon pages of people being brought up before their ethics boards. So if other people are out there doing the same thing, it doesn't necessarily mean it's right. It just means they haven't been caught yet. So again, not ethical. I didn't mean any harm. Well, that's wonderful. But if it did cause harm, then we need to go back and look. Because what is the one ethical principle that just about every healthcare profession has? Above all, do no harm. So we need to go back and look and see what happened. We caused harm, but the client also brought it on himself. So now we're blaming the clients. No, I don't think so. Don't even need to explain that one. Again, excusing it by being under extreme stress. Our job as healthcare practitioners is to be self-aware and to model healthy decision-making and healthy behaviors, which sometimes means taking a step back and going, I am not able to properly serve you right now. If you don't, and you try to use I was under extreme stress, I was burned out, I had compassion fatigue, that's not ethical. That's failing to take responsibility. Well, nobody ever complains when I do it. Oh, that doesn't mean it's right. For example, if you are an out-of-network provider and you are waiving patients' coinsurance, that's technically illegal in most states, even if it's not Medicare or Medicaid, even if it's private insurance. Of course, people aren't going to complain. They're not having to fork out thousands of dollars. Does it make it right? No. We didn't anticipate the outcomes. Yeah, obviously, because you probably wouldn't have done it, but that also indicates that you probably didn't think it through all the way. Because anytime you anticipate outcomes, there's always going to be the good outcome, but we also need to consider the bad outcome. What's the best possible resolution of this? What are the worst possible things that could happen? And how can we mitigate those? Because we don't want to go over here. We want to be on the side of the best possible outcome. There's no universally accepted evidence that it is right, that it is wrong, that it is purple. Okay, maybe, but we're not looking for universal acceptance. We're looking for what's right for that patient at that particular point in time that conforms with the law and that most nearly provides for the client. So we've got to conform with the law, and we want to try to make it as positive for the client as we possibly can. So when we talk about ethics, what we're talking about is this relationship that develops, hopefully eventually between equals, but there's always going to be something of a power dynamic. So one of the fundamental principles of therapy is trust. The client has to be able to trust you. Well, that's wonderful, but you've got to be able to trust yourself first. You have to know that you know what you're doing. You have to know what your backup plans are, and you have to be worthy of trust. Power. Like I said, it is not always an equal relationship. We try to make it as equal as possible, but the state has given us power to treat people. The state has given us power in many cases to initiate involuntary commitment, to report incidences of suspected child or elder abuse. We've got a lot of power. Power given by the person. People come to you and they kind of bare their souls. They make themselves vulnerable. They give us power. We need to make sure not to take advantage of that. There is a fundamental power differential as a result. Caring. We have to care. If you're burned out and you don't care, then you need to take some time off, or maybe even look for a new career. Caring can result in emotional over-involvement, so we need to be aware of those things. We need to check ourselves for transference and countertransference. We need to check ourselves for becoming too emotionally involved with the client or having our stuff, if you will, start bleeding into the patient session. Too much caring can lead to dual relationships, wanting to rescue, getting overly involved. It can be done with objectivity, though. So it's important, again, to look at each individual client and say, okay, no problem with maintaining boundaries and everything here, but knowing there are going to be some clients who walk through your doors who trigger something in you. Does it mean you can't treat those clients? Not necessarily. It's advisable, though, to make sure you have somebody with whom you can consult with to make sure you're maintaining those boundaries and not letting countertransference interfere with the process. We need to be competent in our skills. Don't just read an article about something and go, oh, hey, I think that'd be fun to try. No. Make sure that you are competent in everything you try before you try it with the patient. Rehearse it with a peer, especially one who's already been trained in that. Take a class in it. Make sure you are competent. I would not go into a room with a child and say, let's do play therapy, because I've never been trained in it. Although the state doesn't say you have to be trained in it, I know I'm not trained in it, I'm not competent at it, so I'm not going to do it. That's the difference. Law says, sure, have at it. Ethics says, no. We need to be competent emotionally. If you are stressed out, burned out, compassion fatigued, whatever the case may be, or maybe you've got an issue, a crisis going on in your life, if you know you're not going to be able to focus on the client, the most ethical thing you can do is probably have that client see somebody else, reschedule the appointment, or if the client is in crisis every once in a while, if you're able to ethically do it, you may have to have that discussion before the session and go, okay, we can have a brief session to touch base, but let me let you know I am not on my game today. It's better to have a co-therapist sit in with you in those instances if you decide to go that route. If you're not emotionally available, best case, don't do it. Have a backup plan for your clients. You need to be competent physically. If you show up and you're sick, now I don't mean necessarily under the influence of alcohol or drugs or addicted to anything, which of course would be compromising. But if you have a bad cold and you've just taken a whole dose of Dayquil and you feel loopier than, I don't know, whatever's loopy, you don't want to be going in and trying to sit with a client. If you're going to be dozing off because you're feeling like you're that sick and you can't stay awake, if you are in chronic pain or acute pain and the pain is distracting you from being able to be present for that client, if you have the flu, don't be sitting there with a garbage can in one hand and your notepad in the other trying to listen to the client just in case you vomit. Not going to be a practical session. So be competent emotionally and physically. Make sure you are there for the client. And be competent in practice. Confidentiality, of course. HIPAA regulations, of course. Documentation. One of my pet peeves, documentation. If it doesn't get written down, it didn't happen. Okay? So make sure you document. If you consult with a colleague, document it. If the patient says something crucial, document it. Document a mental status exam, just a mini one, at every individual session. Make sure the person's oriented to time, place, person, and has no suicidal or homicidal ideation. Document just generally how the patient is doing. That way you can see a pattern if they're improving or if they're starting to decompensate. If you've got a full caseload, you're not going to remember every single individual client from week to week, at least not in that detail. Causes of ethical stress. isolation. We need to have colleagues with whom we can debrief. We may not even need feedback. It may just be, oh, let me tell you, I've got this going on. I've got this one client and just sucks the energy out of me. We have those clients. We have them, and it's through no fault of their own. Those are the clients who have such a unstable ego that they need to draw energy from other people, and they can be very draining. We need to be able to debrief. Not breaching confidentiality, not doing anything unethical, but just meeting with another professional who can say, yep, been there. Maybe even give suggestions, stepping over into consultation about, well, when I work with clients that present that way, I've tried doing this, this, or this, or maybe you could try this intervention. Or you can brainstorm about ways you might be able to empower the client and help them move past that. And sometimes it's not because any one particular client is all that draining. It's just you've got a caseload of 30 people. I don't know how you do it. Godspeed to you. I usually try to keep my individual caseload between 10 and 15. Groups, whole different story. But individual clients, it's just, for me, a different type of energy involvement. Know what your limits are. Make sure you don't get into this rut of monotony. That's another reason I love groups, because groups are never monotonous. They always give you something to work with, and generally you can use people within the group to find different perspectives. Make sure you're not seeing, for example, if you specialize in seeing patients with mood disorders. Same 20 patients come in, same 30 patients come in every day, roughly the same story, and they start all blending together. You've lost individualization. You're not looking at each client as an individual. You're looking at them as a group of all my patients are presenting with acute mood disorders. Be aware of monotony and break it up as much as possible. Fatigue. Don't see too many clients on one day. Again, like I said, I try to keep mine around 10 to 15 a week. I don't like seeing more than 3 clients in a day in individual treatment because it requires so much focus and so much energy. Some people can do 6 clients in a day and not even think about it. You need to know your personal limits. Sedentariness. Being too sedentary can lead to stress, it can lead to fatigue, it can lead to a lot of different things. So make sure that you are getting up and moving around throughout the day so you're alert. Make sure you are doing things out of work that don't have anything to do with work, because you need to be well-rounded as a human being. Which takes us to personal nurturance. Take care of yourself. Take a me day. Do things for yourself. Don't put everybody else first all the time. If you're a parent, you know that sometimes everybody else does come first, but you need to make sure to make time for yourself. Self-care, sunlight, oxygen, movement, endorphins, relationships. Sunlight helps you regulate your circadian rhythms, helps you metabolize vitamin D, which can help prevent feelings of depression. It can help you sleep better. Sunlight's a good thing. Now, I'm not saying bake. I'm the first one to put on an SPF of 70 plus. But it is good to be around bright windows. It is good to get out of bed roughly the same time every day. Try to get outside so your body can go, oh, it's time to be awake. We have chickens at our house, and chickens need a 14-hour light day in order to lay eggs. So for the chickens, if their daylight shortens as the winter months come on, they quit laying. The body knows, and the circadian rhythms get wonky. Now, not that we're laying eggs or anything, but it's important to remember that if we're not getting enough sunlight, Our body doesn't know whether it's supposed to be awake or asleep, if we're hungry, if we're not. A lot of our rhythms are set by that internal clock. Oxygen. Did you know the reason that most people yawn is because they're not getting enough oxygen, not because they're tired. They feel tired because they're not getting enough oxygen. So get plenty of oxygen. Belly breathing, not this light chest breathing up here. Belly breathing. Get some good air. Every once in a while, go outside, get some fresh air, unless you live in a place where there's a lot of smog. But try to get some pure oxygen, not pure, but good, clean air once in a while. Movement. A body at rest tends to go to sleep. A body in motion tends to stay in motion. That's not exactly how Newton said it, but you get the idea. We don't want to sit at a desk. I've worked with a bunch of therapists before who create this calming atmosphere in their office. Dim lights, no fluorescence, soft music. After about 2 hours in their office, I'm ready for a nap. So we need to make sure that we're moving around. It's wonderful to have a relaxing area. It's wonderful to be relaxed, but there's a point of too much relaxation. So you need to be aware, again, of your own personal limits. May be fine for them. I couldn't do it, but then again, I'm kind of like a chihuahua that's had too much caffeine. So, endorphins, gotta love them. Those natural chemicals in our body that give us the natural high. We're not always going to get them, but a really good hard belly laugh actually can help release some feel-good chemicals. If you're a runner or a fitness buff, obviously you know you can get endorphins from a good hard workout. Find ways that you can get your happy chemicals flowing, whatever it takes for you. And relationships. We need to have some healthy relationships, work-related. That way we have somebody to bounce ideas off of and for that debrief and consultation and yada, yada, yada. But we also need to have some healthy relationships that have nothing to do with work. You need to be able to set it aside sometimes. We all know people who their entire life is work. When they're at work, and when they're at dinner with somebody, they're talking about work. Well, you got to let it go sometimes and explore other aspects of who you are. Okay, so let's look at some scenarios. A client has come through detox and has been through your program 3 times already. You have open beds you need to fill. Do you readmit him? Okay, he's come through detox, which means, he's physically stable. He's already been through your program 3 times. Now, it doesn't say how recently, but we'll assume pretty recently. Is it in his best interest to go through your program again? That's the question that you have to pose. And if not, what would be an appropriate alternative? Generally, I found if somebody's gone through your program 3 times, your program is probably not getting them exactly what they need. It doesn't mean anything's wrong with your program. It means it's just not the perfect fit for them. So a referral to a similar level of care at another facility that has another approach may be a better fit. There are no other referrals. All the beds are taken everywhere. Do you admit him? If he meets ASAM criteria and he needs to be in residential, even though he's already been through 3 times, and this will be a 4th, probably you would look at admitting him, at least until a bed somewhere else came available. When you admit him, then it's going to be incumbent upon you to look at this particular patient as an individual, what you've done in treatment with him before, what has worked, and do more of that, and what seems to be missing the mark for him, and try not to do as much of that. So you need to individualize the program, and the more somebody comes through, the more individualized it's going to be, which is hard in a residential setting because there is so much structure. But there are ways to do it. So do you need to readmit him? You've got to look at the client. You notice I didn't hit back on that sentence about you have open beds you need to fill. That doesn't matter. I mean, to your boss it matters, but ethically, in the interest of the client, he or she needs to go in the place that is the best fit, that is most likely to provide help to that patient. Worst case scenario, you readmit them to the same program for the 4th time, and it compounds their feelings of helplessness and hopelessness because they've been through your program 4 times and they still can't get it right. So you're going to need to really work hard on creating successes for that patient and trying to help them figure out what it is they need to stay clean and sober. Next scenario. A counselor tells you she's given her clients her home phone number so they can call her whenever they need her. Okay, so how many different problems do you see with this? Number 1, there goes the ability for self-care because clients can call 24/7. Number 2, there's risks for breaches of confidentiality if they call and get husband or kids or grandma or whomever. Number 3, it creates dependency on the part of the client because the client starts to feel like they are unable to cope unless they have a direct line to that one person. We need to encourage people to develop sane, sober support systems on the outside. Who can they call outside of office hours? If there's a crisis, who can they engage with? Is there a crisis center? Are there on-call counselors? Sometimes in communities, counselors in private practice will get together and form an on-call list. So if a patient goes into crisis, there's one person who's on call for a week every 3 months or something. That spreads out the burden, provides the 24-hour coverage, and makes sure that there is someone that the client can reach. It may just not be their particular therapist. A client reveals that she is drinking vodka with Seroquel, an antipsychotic, every night to pass out so she does not have to know when her husband has sex with her. What do you do? Okay, again, let's start by just looking at the problems. Vodka, Seroquel, potential deadly combination. So we've got a problem here. Number 1, the prescribing physician needs to be aware. Number 2, it sounds like the client is not in an emotionally safe environment. So we can encourage her to check into a domestic violence shelter, to go stay with a friend, to do a variety of things. Does she meet the criteria for involuntary commitment? That would be a question that you would have to decide at that point in time with that client. But you do need to make sure that she's aware that the prescribing physician, whom you hopefully have a release of information for, is aware of the combination of the vodka and the Seroquel. Now, most likely, the prescribing clinician is going to want her to go to detox. That would be another option. So look at all your options that are available, knowing that this client is doing something that is potentially lethal. It's kind of like playing Russian roulette. Not to mention the fact that this husband is being abusive. A counselor has a caseload of 75 clients. Godspeed. Her day is booked solid. No doubt. Sally calls in crisis and states she just can't do it anymore, and I can't do it anymore. I'm not going to be coming to my appointment. It's one more thing that I can't do. It's too much on my plate. The therapist says, okay, give me a call back when you're ready to resume treatment, and hangs up, relieved that she has an hour off. My first concern, what is Sally's state of mind? It says she's in crisis, which means it's not just a matter of fact, I think I've reached maximal gains and I've got too much going on right now, so when I've got some time, I'll give you a call back. That's not in crisis. This scenario gives you the impression that Sally's freaking out and maybe making excuses for why she's not going to be coming. So do you just hang up and you're relieved and No, that's client abandonment. If you're able to say Sally was in crisis, or even if you're not, it's really good to check in and make sure that you know where Sally is as far as mental status is going, to make sure that she's not suicidal, homicidal, or in some sort of danger because maybe she's in a violent relationship and the spouse has forbidden her to go to treatment anymore. You need to know what's going on. You can't just go, dodged a bullet on that one. Above all, do no harm. Be aware of what's going on. Err on the side of caution. Oh, and by the way, try not to have a caseload of 75 clients. I know in some situations that's very common, but you can't effectively keep track of 75 clients, even if you're seeing all of them in group. So, really look at your state laws to see what the maximum caseload is for your type of service. Most states, like Florida, will tell you in the state statutes how many clients that a residential counselor can have and how many clients an IOP counselor can have on their caseload at any point in time. Don't pad your caseload by leaving a whole lot of discharged clients or clients that you really need to discharge but you haven't done the paperwork yet, so it looks like you've got more clients. That opens you up to liability. If something happens and they're not officially discharged from your care, but they haven't seen you for 2 months, it could come back on you as client abandonment and dereliction of duty. So, when you discharge somebody, make sure to discharge them. Get them off your caseload. Maintain what is a reasonable caseload for you. And have that discussion with your supervisor as needed. So, ethical behavior involves constant assessment of our own behaviors and motivations. Ethics provides the ideal. A lot of times we're going to be somewhere between the ideal and what the law requires because we're going to have that gray area. Laws provide a minimum standard. We have to do what the law tells us to do. Ethical behavior involves achieving the greatest degree of ethical behavior while maintaining sight of what is legal and best for the client. Thank you very much, and I hope when you go through and read the materials in the class, you will find that this overview provided some insights. Have a wonderful day.